In this video, we will review the different types of validity. As a reminder, validity is the assessment of how well a test measures what it's supposed to measure. The four main categories of validity all contribute to the overall validity of a measure. In this video, we will review face validity, content validity, criterion validity, and construct validity. Face validity is the degree to which a test seems to measure what it claims to measure, based on a superficial understanding of the measure. Face validity answers the question, does this appear to measure what it's supposed to measure? For example, you would expect a test measuring self-care independence to include questions about self-care activities like bathing, dressing, and toileting. For example, the Barthel Index and the Functional Independence Measure both have high face validity for measuring self-care independence. If a clinician reviews these tools, it is immediately clear that they assess activities such as bathing, dressing, toileting, grooming, and feeding. On the surface, they appear to measure independence in daily activities, which is exactly what they claim to measure. Face validity is a subjective judgment of the test's validity based on its appearance. Face validity is usually tested qualitatively using informal assessment of laypeople's initial understanding of the construct being measured. It is inherently subjective and often implied based on the measure's content. Content validity examines whether a test or measurement covers the full range of the construct's domain. It answers the question, how well does the measure capture every part of a construct, and specifically assesses the comprehensiveness and representativeness of the test. For example, intelligence is a very complicated, multifaceted construct. A test that only asks questions about memory would not produce results representing overall intelligence. A test of intelligence should have questions about all domains of the construct: memory, problem solving, creativity, planning. The Wechsler Adult Intelligence Scale, or WAIS, is an example of a measure with strong content validity for the construct of intelligence. Rather than measuring only one domain, such as memory, the WAIS includes subtests assessing verbal comprehension, perceptual reasoning, working memory, and processing speed. Because it captures multiple domains that make up the broader construct of intelligence, it demonstrates strong content validity. Like face validity, content validity is most often assessed using qualitative subjective comparison. Researchers assess content validity by comparing the method of measurement against the conceptual definition of the construct. Criterion validity evaluates how well one measure aligns with an outcome based on associations with another similar measure. It answers the question, how well do scores on this measure correlate with other related variables? A criterion is defined as any variable that you'd expect to be correlated with the construct being measured. For example, a measure of sleep quality should correlate with a measure of tiredness. The Pittsburgh Sleep Quality Index, or PSQI, demonstrates criterion validity if its scores correlate strongly with objective sleep data from polysomnography. For individuals who report poor sleep quality on the PSQI, also demonstrate disrupted sleep patterns on polysomnography, this supports criterion validity. Criterion validity includes two subsets of this concept: predictive validity and concurrent validity. Predictive validity is the extent to which test results predict some criterion measure in the future. For example, a measure of sleep quality should correlate with level of tiredness throughout the next week, and we can say that the sleep quality measure demonstrates predictive validity with future level of tiredness. In rehabilitation, the Berg Balance Scale, or BBS, has demonstrated predictive validity for fall risk. Lower BBS scores at discharge from inpatient rehabilitation are associated with a higher likelihood of falling in the months following discharge. Because the score predicts a future outcome, falls, the measure demonstrates predictive validity. Concurrent validity is the extent to which test scores correlate with scores on another gold standard measure taken at the same time. Test results should correlate to some similar outcome. For example, a measure of upper body functioning should correlate with a measure of hand dexterity taken during the same physical therapy session. The 6-minute walk test demonstrates concurrent validity if its results correlate strongly with peak oxygen uptake, or VO2 max, measured during a graded treadmill test administered during the same session. If individuals who walk longer distances on the 6-minute walk test also demonstrate higher aerobic capacity on the treadmill assessment, this supports concurrent validity. Testing criterion validity usually involves comparing results from the new test in question with results of some other measure that you expect relates to the target construct. A positive correlation indicates the two tests are measuring related constructs. Construct validity assesses whether a test or instrument truly measures the theoretical construct it intends to measure. It answers the questions: how closely do these results correlate with results on an existing test that measures a similar construct? Usually this means comparing a new test to a gold standard measure that's used often and accepted in the field. Suppose a researcher develops a new anxiety screening tool for use in outpatient rehabilitation. To establish construct validity, they compare scores on the new tool to scores on the Hospital Anxiety and Depression Scale, or HADS, which is widely accepted in clinical settings. If patients who score high on the new anxiety measure also score high on the anxiety subscale of the HADS, this supports construct validity. Convergent and discriminant validity are two subtypes of construct validity. Convergent validity is the degree to which two measures of constructs that should theoretically be related are actually related. For example, people who score high on a numerical pain scale should also score high on a pain perception scale, because pain rating and pain perception are highly related constructs. Conversely, discriminant validity is the opposite of convergent validity. Discriminant validity is the degree to which measures of fundamentally different constructs should not be related. For example, a measure of happiness should not be correlated with a measure of sadness. To evaluate convergent validity, a researcher might administer both the numeric pain rating scale and the McGill Pain Questionnaire at the same visit. A strong positive correlation between the two would support convergent validity because both are designed to measure pain. To evaluate discriminant validity, the researchers might compare scores from the numeric pain rating scale with scores from the Mini Mental State Examination, or MMSE. Because pain intensity and cognitive status are theoretically distinct constructs, little to no correlation between these measures would support discriminant validity. To test construct validity, researchers usually administer two tests at the same time and collect data to assess the strength and direction, positively or negatively, of the correlation between the results of the tests.